confirmação. Ok, então está confirmado. Então agora gostaria de chamar o painel internacional, né, passar a palavra para o Dr. Guy Fones, que eu já apresentei quando eu fiz a minha apresentação inicial. Então, Guy, thank you very much. I have introduced you previously, and it's an honor to have you again here with us at the Forum CCNTs meeting, this time the 15th meeting, leading this rich and intense panel with topics that we can't wait to hear more about from those specialists that you will moderate. Thank you very much.
There we go. Thank you so much. Muito obrigado, Mark. Yes, thank you so much. And a warm welcome to all. Thank you for Mark already highlighting the very important discussion we will have. Let me bring up some of my documents here and try to find them. There we go. Thank you so much again. You've already, and I'm sure in the discussion you had in the intro, I joined halfway through, you had very important insights from the participants in this meeting. And I think we'll go deeper into some of those areas of concern and some of the opportunities to accelerate actions on NCDs in this session. So my name is Guy Fones, and I am Director at Intrim for the WHO Department of Non-Communicable Diseases, Rehabilitation and Disability at headquarters here in Geneva. It's a pleasure to join you. And let me start with a few overarching words and a few messages. I think this is certainly a very, very unique and valuable opportunity. WHO countries and partners are full speed ahead in the preparatory process for what needs to be a transformative fourth high-level meeting of the United Nations General Assembly on NCDs, which is planned for September of 2025. The argument for an urgent call to action is undeniable. Non-communicable diseases, including mental health conditions, are responsible for the majority of global deaths annually. To be precise, it's 75% of all non-pandemic related deaths in 2021. And they represent a leading cause of morbidity and disability. However, more than halfway into the SDG era, the world is definitely not on track to meet SDG target 3.4, which is to reduce premature mortality from the main NCDs. Only 19 of the WHO's 194 countries and territories are actually on track to meet individual targets, but overall progress remains concerningly insufficient. And ultimately, the real reason this call to action is so urgent is that we need to address the stark reality that every 2 seconds, someone under the age of 70 dies from an NCD. During our 90-minute session, we will have lost an additional 3,000 lives to premature and largely preventable NCD deaths. The persistent underinvestment in health services means the gap between the need for and availability of quality care and support remains as wide as ever. These gaps were exacerbated even more by the impact of COVID on those at risk of and suffering from NCDs. The good news, dear all, is that we do know what to do. And we will be showcasing some of those accelerators in today's session. Many of the deaths and disabilities due to NCDs and mental health conditions could have been and still can be prevented through concrete measures known as the WHO Best Buys, which include reducing the shared risk factors, but also improving access and quality of healthcare, ensuring universal health coverage, and tackling the commercial determinants of health, to name a few. As we shape the ambition for the world post-fourth high-level meeting on NCDs, for 2030, for 2050 and beyond, addressing this devastating trajectory for people living with NCDs and mental health conditions will ultimately require reorienting health systems to primary healthcare as a resilient foundation for universal health coverage and health security, fully inclusive of and responsive to the underserved and most vulnerable. At the fourth high-level meeting on NCDs, we need to get it right for those who are counting on us. We need to address the preventable premature death, the predictable ill health, the crippling pain, the unnecessary disability, the unethical financial hardships, the stigma, the discrimination, and the outrage of billions of people living with and affected by NCDs and mental health and neurological conditions. In this session, we hope to provide you with examples of accelerators, feasible, achievable options and solutions to fast-track NCD prevention and control. We look into healthy diets, social participation, and closing the diagnostic gap. I invite you for the session, and without further ado, we will launch the panel discussion with 3 panelists. Each panelist will have 15 minutes, up to 15 minutes to delve into their topic. We will go through the 3 panelists and then come back to you, participants, for hopefully an engaging discussion on what you have heard and some of the comments you may have. So it's my pleasure to open up with the first panelist, Camila Gabe, from the Department of Nutrition at the University of Sao Paulo. Camila, we are 10 years since the launch of the Guia Alimentar para a População Brasileira. What are some of the main public policies related to NCDs that this guide has accelerated?
Hi, good morning, everyone. It's a pleasure to be here to talk about the food guide, the Brazilian food guide. I will share my screen. Can I? Just a second. Okay.
We can see your slide.
Okay. My name is Camila Gabe. I'm a postdoctoral researcher at the Center of Epidemiological Research in Nutrition and Health of the University of Sao Paulo. And I've been working with the food guide since during all my PhD. And it's a very important document that represented a revolution in the way we see the relationship between food and health in Brazil. So we'll bring some concepts of the implementation and also the context of the food guide in Brazil. So I've divided my presentation in 4 topics. I will start by bringing some characteristics and the political context of the food guide when it was launched in 2014, and then some of its main recommendations and why they are very important for chronic disease prevention and mitigation. And then I'll move to bring the actions for the implementation that were carried out in Brazil since it was implemented in 2014, and then some challenges and perspectives. So I would like to start by bringing that it's very important to consider, to highlight that when it was launched in 2014, this food guide that brought a holistic concept of healthy eating in Brazil, we had a very favorable or good political context. We had a food guide in 2006 that was based on another paradigm of healthy diets. It was based on nutrients and the paradigm of the food pyramid, and we changed it completely in 2014 to bring a more holistic concept of healthy eating. In this period between 2016 and 2014, we had the National Food Policy of Nutrition, Food and Nutrition Security in 2010, the human right to adequate food in the federal constitution in 2010 too, and the national food policy, policy of food and nutrition in 2011. It's also important to highlight that the food guide is a document from the health sector. So the health sector is the sector committed to coordinating and developing international intersectoral actions for the implementation. It is part of the National Policy of Food and Nutrition, the PNA, And among the guidelines of this policy, the food guide is part of the guideline of the policy for the promotion of adequate and healthy eating. So it's a document used in Brazil for the promotion of adequate and healthy eating as part of this policy from our health system. In terms of recommendation, our food guide brought this for the first time, recommendations totally based on food processing. So it has as a golden rule, always prefer fresh and minimally processed foods and its culinary preparation to ultra-processed foods. So it's basically, it highlights that Brazilian population should avoid this group of foods and prefer our traditional diet based on rice and beans, and that are the core of our traditional dietary pattern in Brazil. This recommendation in 2014 has proved to be very pertinent, because since then we have building consistent and strong evidence on the association between ultra-processed food intake and health outcomes. So now we have this umbrella review of meta-analysis published in 2014, 2024, sorry, this year, showing that the ultra-processed food intake is associated with at least 32 health outcomes. So the prevention of chronic conditions goes through avoiding and reducing ultra-processed food intake. In terms of implementation of the food guide, we, in the NUPENS, we proposed this conceptual model for the implementation of the food guides in general, and we analyzed the implementation of our food guide in Brazil according to this conceptual framework. And we highlighted here that for implementing a food guide, it's important to have actions on these two dimensions, which are using the food guide as an educational material to communicate what the country considers a healthy diet for its population, but also to implement, to induce public policies based on the recommendations of this food guide. So in terms of dissemination, when the Brazilian food guide was implemented in 2014, the Ministry of Health made several partnerships with institutions in Brazil to disseminate its recommendations. So many materials based on the recommendations were developed. These materials targeted different settings and actors. So we had some of them were made for promotion of healthy eating in schools. Other of them were for primary health care. So these were made in partnership between Ministry of Health and public institutions in our country. In terms of public policies, the more recent of them was the update of the composition of the National Basic Food Basket through a portaria from the Ministry of Social Development. So this update of the food basket was completely based on the recommendations of the guide. So we had another food basket before that had a restricted number of fresh and minimally processed items. So this new food basket expanded and diversified the number of these foods. It also valued the country's regional diversity by including different kinds of fruits and vegetables that are part of our biodiversity. And the implication of this is the use of this list of the basic food basket for the exemption or reduction of taxes for these foods that are part of the food basket. We had recently too, last year, a publication of a regulation for the promotion of adequate and healthy eating in the school environment. So this regulation determined that all the actions for promoting of healthy diets, healthy eating in schools environment must be based on food guide. And this include not only actions on nutrition education, but also actions on the provision and commercialization and marketing of food and beverage in schools. One very important change in our law in Brazil based on the food guide was the update of the National School Feeding Program in 2020. So we had this large national school feeding program in Brazil that serves more than 40 millions of meals in Brazil every day. So the change of this law has a very broad impact in changing the meals that are offered in schools. So then this new resolution determined that at least 75% of the money that is transferred from the National Fund for Educational Development must be allocated to purchase of fresh and minimally processed foods. And the acquisition of the processed and ultra-processed foods was limited to 20% of this budget. And finally, when the guide was published, the Ministry of Health published this regulation to prohibit the ultra-processed foods in all institutional environments of the Ministry of Health. So it was prohibited the provision, commercialization, and advertising of ultra-processed food in workplaces linked to the Ministry of Health. Besides the federal level, there's some regulation related to states and municipalities. For example, some municipalities that have prohibited the ultra-processed foods in school cafeterias. In Brazil, some examples are Rio de Janeiro and Niterói. And there is a law project in São Paulo under analysis. In terms of the implementation in the healthcare, in our SUS, our health unified health system, there's this is a project in partnership between the NUPENS USP and the Ministry of Health to train health professionals to implement the recommendations of the guide and their professional practices. Because as the food guide represents this change of paradigm, it's very important to implement this in changing health professional practices. So it started by the development of these 5 protocols of how to give nutrition, food and nutrition advice to in the individual level in the primary health care. Primary healthcare units in Brazil. These protocols were developed and in a project between NUPENS USP and Beneficência Portuguesa under the PROAD SUS program. A course for implementing these protocols were developed and made available in the UNASUS platform. For training the professionals. And this was launched this year, this course. The implementation of this course was, this project of developing and implementing this course was a big project and involved visiting many municipalities in Brazil to train and to stimulate the managers of each city to train and to stimulate the health professionals to make the course in the UNASUS platform. So to finish my presentation, I'll just mention some challenges and perspective. So one of the challenges of the implementation of the food guide was the political discontinuation that we had in the past years. So one example of these that have impacted in the implementation of the guide was the extinction of the National Council of Food and Nutrition Security from 2019 to 2023. And this council was a very important actor on the planning the implementation, helping to plan the implementation of the food guide. And it represented the destruction of our health system on food and nutrition security during this period. Also, the conflict of interest in policy decision. The taxation of ultra-processed food is also something that is under debate in our tributary tax reform in Brazil. This was a very important discussion, and now it's under discussion if the taxation of food, of beverage, sugary drinks is been decided. And to finish, the monitoring and evaluation of the implementation of these policies and how they impact the intake of ultra-processed foods is something that we need to pay attention and to strengthen. So thank you, everyone. I'm open to discuss and to answer the questions you may have.
Thank you so much, Camila. Really impressive, and congratulations to you, to the team, to Brazil. It's really impressive demonstration of systems approach to really addressing this issue. And we hope to come back in the discussion on many of your points, but I just take note of this is not necessarily only a very powerful technical guidance and technical tool to prioritize, design, implement policies, effective policies, but it really is that systems approach where you address, health literacy, health workforce, participatory approaches, and the important opportunity and now challenge of the cross-sectoral coordination and stakeholder coordination, which you had at the beginning. Now you know that may have slightly been weakened, and those are sort of what you're pointing towards, sort of success factors of such an approach that we need to consider. And then the additional challenges, which I think may cut across other presentations on conflict of interest, undue influence, and additional regulatory and fiscal policies which need to support policy interventions on the ground. We need sort of nationwide regulatory and fiscal policies to continue to sustain some of these actions. So maybe we can get back to that because it does touch on some of the other presentations. Thanks so much, Camila. We'll move on to our next panelist, which I'm really proud to present, my WHO colleague, Kira Koch, who has spearheaded the milestone WHO resolution on social participation. Kira, how can social participation, including the meaningful engagement of people living with the health conditions, in this case, NCDs and mental health, ensure a participatory co-creation process in health decision-making process at national or even global level? To you.
Yeah, thank you very much, Guy, and thank you very much to the organizers. I am now also trying to share my screen, and I hope you will be able to see my presentation now. Okay, I think that should work. Perfect. Yeah, thank you very much, Guy, and thank you very much to the CCNT Forum, in particular to Mark and the team for the invitation to speak today to you. The topic of our session is on accelerators. Guy had just mentioned it, and effective policies for NCDs in Brazil and worldwide. And we've just heard from our previous speaker, Camilla, about one of the great achievements of the Best Buys on the healthy diet and food strategy in Brazil, where some of the participatory processes elements have already been touched upon. So in my 15 minutes, I like to focus more on the meaningful engagement of people with lived experiences, and basically coming to the question on how we can really amplify the voices of people, communities, patients living with NCDs, caregivers, so that the policies, the strategies, and the plans are more responsive, such as, for example, to their needs, such as the NCD action plan, the food and nutrition guidelines that we just heard about, ultimately to ensure that they are more effective in enhancing surveillance, prevention, and control of NCDs, and enhancing overall health outcomes. Now, let me start by mentioning what is social participation in the first place. And of course, we are acknowledging that there are many, many terms used in different country contexts, like social participation, public participation, community engagement, community empowerment, health democracy. Now, when we refer to social participation, we very much look at it from a health systems governance perspective, to ensure that the people's views, demands, needs are fed into policy strategies and plans to make them more responsive to their needs. WHO defines social participation as empowering people and communities through inclusive participation in decision-making processes that affect health across the policy cycle and at all levels of the system. So it can really be at the national level, at the subnational level, at the local level, and across the full policy cycle. And let me be clear here, when I talk about the policy cycle, it's really from the assessment, the priority setting, the policy development, implementation, and monitoring and evaluation. So we may want to think about a public hearing process, or public hearings during the process of drafting a UHC law, participatory mechanisms for priority setting through health technology assembly, large-scale population engagement to develop a new national NCD strategy, or review processes by district health committees to optimize NCD service operation. It's really about the two-way dialogue, the back and forth, instead of the one-way communication to the public at large. It's about safe and constructive spaces by mitigating power imbalances. And we will talk about how we can actually achieve addressing these power imbalances and, importantly, addressing the conflict of interest as well. It's about ensuring inclusive participation and, very importantly, valuing the lived experiences, as well as making those participatory spaces more regular and sustained over time. Now, why do we see that this is critically important? Social participation or participatory processes, first of all, is a fundamental component of the right to health and reflected in the right to participation. Now, from a health perspective, let me give you three main points. Social participation, first of all, is a key component of the primary healthcare approach. You can see here on the screen also the primary healthcare approach, the three components in the diagram reflected here. Besides the integrated health services and the multi-sectoral policy in action, it's also critically to empower individuals and communities. And as such, social participation can promote equitable progress towards universal health coverage by amplifying people's voices, in particular those of marginalized and vulnerable groups, to influence decisions so that policies are more responsive to their needs. It's around co-ownership and thus also ensuring greater acceptance of decisions, which leads to broader implementation. The second point is around social participation fostering trust and health systems resilience. I think we have all seen it across the COVID-19 pandemic, the need to engage with people and communities to better understand their daily challenges, including in terms of emergency response, but also in terms of the dialysis patient needing to get their treatment, or diabetes care needing to have the regular checkups that are requested, and as well as strengthening civil society engagement to reach those furthest left behind. But we also realize that trust is not something that can be built overnight, and it takes time. And that's why it's important to invest in these social participation mechanisms so that they can then leveraged in service of the next emergency. And lastly, importantly as well, is that social participation advances key principles of health systems accountability and increases transparency, and it allows for policy adaptation through feedback triggered by different and regular engagement modalities. Now, the big question, of course, is how can we make it work? In 2021, and you may have come across, WHO has published the Handbook on Social Participation. I've put in here below the link in English. It is also available in Portuguese, so do please have a look and peruse through it as you see fit. There have been a lot of literature reviews that we have conducted. You will also find 9 country case studies from across the world, across the regions, from Thailand over Portugal to India, etc., where we really have drawn from the practical recommendations in order to put these forward in the guidance document. Now, here you can see the handbook concept. What I want to mention here, it's really that it's focused on the target audience of policymakers. You can see this in the green box, member states, governments, and how they can more meaningfully engage through modalities, for example, directly with the population, with citizens, etc., through communities, and here very much recognizing the vast experiences of community mobilization, especially in optimizing service delivery, as well as via civil society as important intermediaries in order to then steer policy dialogue and policy strategies and plans, overall health sector efforts towards achieving universal health coverage, and including, of course, adjusting and enhancing NCD prevention and control. Now, the key issues for policymakers to reflect on when they are setting up, strengthen, or institutionalize ultimately these social participation processes. Now, this is actually how we are following through the chapter. So I will briefly make a remark on each of these points. First of all, participation is a core instrument for voice, agency, and empowerment. We can see a lot of different varieties of participatory mechanism. Now, there is, however, no blueprint, which is not surprising. So it's again around the mix of mechanisms that is important in order to hear from broad and varied voices from society. In France, for example, last year they had the end-of-life discussions and consultations where they have organized over 500 regional debates, consultative meetings. A citizen jury was put in place where around 180 randomly selected citizens came together as part of a citizen convention to put forward recommendations. The second point is to reflect on how to enable an enabling environment for participation. And ultimately here we come down to the topic and the issue around power dynamics, because we know that power dynamics are ingrained in the country's political, social, and economic landscape, and they create unequal conditions for participation as they pose structural barriers to participation, mostly for those who have less voice and influence, while inadvertently they increase access to decision-making structures for already those who enjoy a larger portion of influence and power. So meaningful participation is really brought about by evening out the playing field as much as possible. And what we mean by that is counterbalancing the inherent and ingrained power imbalances that exist in every society for purpose of that participatory space. So we need to think through about acknowledging in the first place that they exist, but also how we can address them, how we can address conflict of interest. And this is done through a thoughtful reflection process of format and design, for example, preparing meeting materials in advance in plain language, the meeting location, etc., but also through capacity building initiatives. The third issue, which is often at the very core, is the issue around representation. And here it comes down to who is actually participating and who is not participating, and subsequently reaching out to those who are not participating, who are usually those who are in vulnerable and marginalized situation. And this is critically important for the legitimacy and the credibility of the overall participatory process, also in order to ensure that the policies are then acceptable and enjoy the credibility to be implemented. But how we see in many cases that still a lot of tokenistic approaches are currently the case, where maybe one or two civil society representative is invited, or a person with a lived experience. But we need to avoid these tokenistic approaches and ensuring that there's a meaningful engagement in these participatory processes. The fourth issue, of course, is around capacities. And here our plea in order to invest in capacity building initiatives, not only for government actors, but also for civil society. So it's on both sides that is important. For government in particular, the added value of understanding that this is something that is helpful for them to do their work in terms of developing policies, but also for civil society. And a great example comes from Slovenia. For example, the youth network No Exclude Slovenia has been invited to build the capacities among young people, and they then were able to advocate successfully for stricter tobacco control, especially when it comes to youth consumption of tobacco products. The fifth point, of course, is around policy uptake. And we know that there are many participatory processes out there, but then the question is there, or a gap is there, on how these participatory process results are being adequately taken into decision-making processes. Now, one of the role models that we can see across countries is coming from Thailand. For example, Thailand has the Thai National Health Assembly. It's a large participatory platform, and it really goes by the motto, which I find very pertinent, the triangle that moves the mountain. And the triangle here is government sector, the academia sector, and the people sectors. And each, importantly, are represented in equal terms, 1/3, with equal voting rights. Still, of course, the resolutions are not binding, but they have, over the years and decades, improved their mechanisms. So now you will find, for example, a resolution committee follow-up in order to ensure there is the necessary policy uptake to improve implementation and ultimately outcomes. Now, the issue around legal frameworks, of course, there are many frameworks also in order for the enabling environment that needs to be put in place. And again, they can help also to recalibrate the balance of power. The Thai National Health Act, for example, was the legal provision to establish the National Health Assembly that I've just mentioned, but also in terms of its composition and representation of people's voices to be part of the decision-making table. But it's good to keep in mind, of course, that this is not, legal frameworks are not a guarantee for participation per se. It is one of the elements. In Portugal, you will have the National Health Council. They are active since 2017, but the basic law actually has been there for more than 2 decades previously, but it needed the political commitment as well and the resources in order for it to be put into place. And lastly, I think very importantly is also to move away from the ad hoc engagement towards one which is really sustained, which is part of the modus operandi of governance approach on meaningful engagement, people, communities, and civil society. Now, there are different tools, but one tool that I definitely wanted to mention here in our forum is the WHO framework for meaningful engagement as well of people living with NCDs and mental health and neurological conditions. The reason why also is that it illustrates an important example of co-creation of co-creating joint recommendation and underlining the importance of listening and learning from people with lived experiences. And we can see here in the quote by Anu, the expert, pointedly saying that because others do not understand what it is like to live with NCD, it is important to listen to me as one person living with an NCD in order to better understand what it means in my perspective and my challenges and what I can contribute towards the dialogue. And I think importantly, doing so along the principle of dignity, respect, power, equity, inclusivity, etc. So it's important to understand and acknowledge this this evidence in addition to the other resources and evidence that is existing. Now, a few words on the global movement towards more meaningful engagement. And I allow myself why it is a very important year as well, 2024. Some of you may know, Guy, you had just alluded towards it, this May in the World Health Assembly, all WHO member states have adopted the resolution on social participation. So it's a key milestone for us, for all of us, in order to now use the political commitment to drive progress in countries. And it has been, and I won't go into details, a long process building up towards the adoption of the resolution, with many consultations, with many actors having been involved and advocating at the different levels in order to drive change. What I wanted to mention was the core group of member states that supported the resolution on social participation. It was led by Slovenia and Thailand, but the core group also included Brazil, France, Norway, and Tunisia. And in terms of Brazil, you will know this better. A lot of the experience, of course, in your country has been put towards the table, social participation being entrenched in the constitution, large experiences of participatory processes, including the National Health Council, who was also part of influencing the discussions and consultations that went into the resolution text. And in my last 2 slides, I briefly just wanted to mention what is actually being put forward in the resolution text, and which reflects the commitment by member states in this important area. First of all, member states have committed to strengthen public sector capacities. Secondly, enabling equitable, diverse, and inclusive participation, with particular focus on the voices of those in vulnerable and marginalized situations. Thirdly, it's about influencing transparent decision-making, striving to ensure that social participation influences transparent decision-making, force on the implementation, but also on the sustaining regular and transparent social participation, backed by legal frameworks. Fifth, the allocation of adequate and sustainable public sector resources, both in terms of human and financial. Sixth, facilitating capacity strengthening for civil society. And lastly, the support of related research, in particular also on monitoring and evaluation. Now, on this slide, it is basically towards us from WHO, and we stay committed to supporting member states and a driving process in the implementation with member states, but also, of course, with civil society in this regard. From our side, it will stay important to focus, to keep and use the political momentum at the moment to drive progress in countries, to develop technical guidance and operational tools, as well as to disseminate the large experiences from different member states, but also the regular sharing and exchange of those experiences to better understand what worked, what didn't work, and equally to harmonize technical support across the different technical areas in WHO. By that, I may just want to mention that we are in the process of establishing a WHO multi-stakeholder network as well. And once it is established, it would be, of course, fantastic to have some of you being part of it in order to also learn from the experiences in your respective country, the challenges as well as the opportunities, in order to really move towards a process and a possibility for meaningful engagement, which is really regular and institutionalized over time, which means adaptation and constantly improving, which of course is necessary, but we hope by that, of course, to have a key contribution in order to enhance equity and enhance health outcomes, and equally in this regard, relevant to our discussion today within the NCD space, to improve also support and enhancement towards the SDG 3.4. And with that, I thank you very much. Obrigada. Over to you, Guy.
There we go. There's an issue with the mute there. Thanks so much, Kira. This is such a powerful presentation. Actually, for those listening, this is a masterclass in social participation. I especially enjoyed it also, and I've been part of this process, but it was an excellent presentation, Kira. It demonstrates WHO's, first of all, WHO's commitment. This is not necessarily a nice thing to discuss. This is WHO's commitment to effectively implement social participation in WHO's work. And supporting member states do the same. It's a very powerful message, because ultimately WHO is really what WHO is really saying is that we will not, it's not that we may not, we will not deliver effective, contextual, sustainable policies on the ground if we do not shape them by the experience of those communities and people, individuals, and those with lived experience of NCDs, of multiple diseases, in this case, NCDs. So it is really the recognition of the value of experience of navigating health systems in whatever health condition, or in addition to other intersectional experiences. That experience is expertise that needs to shape policies and programs in order to make them equitable, effective, contextual, and to leave no one behind. We remain with huge pockets of underserved populations, because we have not understood how to shape policies to address those more contextual needs. And we need to understand what are the challenges, bottlenecks in navigating health systems on the ground to address those bottlenecks. So I think there's a masterclass, there's much to learn from. There's a question in the chat here that points to, how can we implement this? But I think you've answered that question very well. And I think I direct that participant to the chapters of the Kira mentioned, which is really how to. It's complemented also by the framework of meaningful engagement, which sits squarely within the specificity of those with lived experience of health conditions. It's a subset of the broader social participation ecosystem. But very important there. You also find some how-to and some of the guiding principles and actions that can be taken. So I think that's an excellent, and it's a nice segue to our next panelist. Thank you, Kira. I welcome Beatrice Vetter, Director for NCDs at FIND. This does have much relevance to our previous discussion. We will now discuss the access to diagnostics and sort of how we can unpackage some of the bottlenecks there, which are really driving the pain, the suffering, the premature mortality of those living with NCDs. So the question is sort of clear. Is it right to say that the lack of early and timely diagnostics and frequent monitoring are among the main bottlenecks to achieving SDG 3.4 and delivering better responses to those on the ground? With you,
Thank you. Thank you, Guy, and thank you, Forum CCNT and Mark, for giving me the opportunity to address a little bit the dire lack in access to early diagnostics and monitoring for non-communicable diseases. So my name is Beatrice Vetter, and I'm the director of the NCD program here at FIND. I'm based in Switzerland. FIND is an international NGO working to address the lack or equitable access to diagnostics worldwide. We work in different disease areas, of course, infectious diseases, as well as non-communicable diseases, about which we will talk just now. So as Guy just mentioned, so the question really is here for the next 10-15 minutes to reflect a little bit on saying, is it right to say that the lack of early and timely diagnosis and frequent monitoring are among the main barriers to achieving SDG 3? And I want to take you through a few examples, as well as some background information in general on where are we today with access to diagnostics, and what opportunities are there to overcome some of the barriers that we are seeing. So here's the situation. So this graph was published in the Lancet Commission on Diagnostics in 2021. And it shows you the care cascade for diabetes and hypertension. So you can see number of all people living with either of those two conditions, number of people screened at a screening event, then number of people receiving a confirmed diagnosis, number of people treated, and number of people controlled or treatment completed. I think we'll probably say successfully enrolled in care and staying in care. And as you can see, the situation is quite dire. So less than 50% of people with diabetes or hypertension are diagnosed, while a few more receive initial screening tests. There is a gap in drop-off between screening and confirmed diagnosis, and fewer than 1 in 4 people are successfully treated. So really, what the Lancet Commission then said, okay, what if we were to increase these numbers to 90%? How much impact would it actually have on death avoided and disability-adjusted life years gained or averted? So by increasing the number of people diagnosed to 90%, an estimated 0.6 million deaths could be avoided and 14.7 million DALYs averted annually. And I think it's the DALYs that are so critical for NCDs, because of course one can live with an NCD, but with chronic complications and frequent, disabilities and inabilities to work, that is a massive amount of lost lifetime, lost quality of life, as well as lost workforce to any country or community. So yes, the lack of diagnostics and monitoring are key, if not the only ones, barriers to achieving SDG 3.4 based on these data. So what can we do to close this diagnostic gap, to get closer to the 90 rather than what we see now, the less than 50%? I want to talk today about 3 principal approaches. One is bringing testing closer to the community through point-of-care technologies and self-testing. 2 is integrate testing into other health initiatives, because of course we know NCDs often take a long time before they present with symptoms, whereas acute infections, for example, or other health concerns motivate people to seek healthcare, and that's an opportunity to engage with them around any underlying non-diagnosed NCD. And of course, also we must strengthen the linkage to care. And I will show you an example how critical it is to actually also achieve good enrollment in care and treatment, and what the gap is for the linkage. So just a brief sort of technical slide, right? When we talk about point of care and self-testing in the example of diabetes and hypertension, what are we actually talking about? What kind of technologies are we talking about that we need to make sure people have access to? So when we look at self-testing, which is critically important for people living with chronic conditions, because someone with a chronic condition spends 95% of their lifetime at home managing their own condition, and only 5% with a healthcare provider. So the very basic self-testing tools are, of course, blood pressure monitors that can be used at home, blood glucose meters as a traditional tool to check blood sugar for diabetes, and then the newer technologies for diabetes management, such as the continuous glucose monitors. These are not so much topic of my presentation today, but I want to highlight them because they are so critical, particularly when it comes to monitoring. And we know that many people are not able to self-monitor strongly at home because the commodities are expensive and frequently not provided well through government schemes. When we look at community testing, so this is sort of outside structured health facilities, but taking the products and the technologies into the community. Of course, again, we have the blood pressure monitors that can be used by healthcare providers, community health workers, anyone who is engaging in health community screening events. Blood glucose meters and test strip can easily be taken in the community. And then there are portable devices. Here's the example for the glycated hemoglobin device, which is often also used in diabetes screening. So these are quite easily and portable to take to the community. And then we can look at the primary healthcare level, which of course is so critical as a first point of call for people when they maybe had an elevated screening result or they have another health concern. And here the technologies can be a little bit more stationary. So we have slightly larger devices for glycated hemoglobin that sit on a table. We also have cardiometabolic point-of-care devices. So these are useful because they can test for multiple parameters, like your cholesterol, creatinine, the glucose also, and the glycemic index, as well as maybe other cardiovascular disease markers. Yet they are still small enough to be used in a facility that does not have high infrastructure and laboratories. Of course, the blood pressure monitors are used in primary healthcare, as well as, again, the blood glucose meter as a technology. So with this in mind, we actually started to ask some questions on implementation. You know, does it actually work? You know, sort of what can these technologies for point of care testing do to improve diagnostic rates, and do they actually improve diagnostic rates? You know, so we partnered with Chronicas, an affiliate of the University of Peru, and basically asked the question: will point of care testing improve diagnostic rates compared to standard of care external lab testing? Because of course today we know that often when someone seeks care in a primary healthcare facility, they get a venous blood sample taken, which will then need to be sent to the laboratory, which will then have a certain turnaround time for results, and there is a high risk of loss to follow-up. Or maybe the patient needs to get the result before they come to the healthcare facility, and then plan this ahead, and there will be costs incurred, which can also stop them from actually getting these. So what we did was we looked at implementation of multi-parameter point-of-care devices for NCDs at primary healthcare level in urban and rural areas of Peru. And this is an example of the device. And again, it tests, you know, for lipids like the cholesterol, creatinine for kidney disease, as well as diabetes through glucose and glycated hemoglobin. And the results really showed that, as an example, in diabetes, how many new diagnoses of diabetes did we get with using point of care at primary healthcare in comparison to lab-based results. The patients were always received at the primary healthcare facility, but in one arm, they were receiving a test there and then with a healthcare provider. And in the second facility, they would go through the standard testing, taking a venous blood sample, sent to the laboratory. And what we found is that 13.3% of people were newly diagnosed at the primary healthcare level when a point of care test was available. And actually half of that, 7.6% of people were newly diagnosed at PHC primary healthcare level when only standard of care external lab testing was available. So basically, twice as many people were newly diagnosed with diabetes when a point of care device was present. And the effect was particularly strong in the rural areas. And of course, it's not difficult to see why that is, because in the rural areas, access to the external centralized laboratories is even more difficult, sample turnaround time is much longer, and the loss to follow-up is higher. So point of care testing can reach more people and provide a diagnosis during the consultation, avoiding loss to follow-up. Because of course, these devices, the way they work is that the patient gets their finger pricked. There is a small sample collection device that goes into the testing machine as shown here. And within 10-15 minutes, the result is available. So basically the patient can wait while doing this. So not only can these be placed in primary care facilities, but the result turnaround is much quicker. So this is very promising in terms of a result, that point of care testing technologies are a way to close the diagnostic gap that we've seen before. Now I want to give you an example about integrated testing. So the second solution I proposed previously was to say there are health drive efforts where people seek healthcare for other reasons. So here, is this an opportunity to integrate screening and testing, for example, diabetes, as well as, say, hypertension? So what we did during COVID-19, where of course a lot of people were motivated to seek health and healthcare, is that we said, let's try integrating of NCD screening into public health center COVID-19 vaccination efforts. And this study was conducted in South Africa. So a lot of people went to a specific center to get their COVID vaccine. And we wanted to evaluate the feasibility, yield, and linkage to onboard care of rapid screening for diabetes and hypertension, alongside an existing COVID-19 vaccination program. And importantly, we also wanted to assess the total cost, because of course, it's one thing about showing that it works. The next question from any implementer or policymaker will be, well, how much does it actually cost me? So we had a study population of over 1,300 people attending a public health facility obtaining a COVID vaccination. And overall, we found that the diabetes prevalence was 4.1%. The hypertension prevalence was 19.1%. And importantly, the potentially newly diagnosed was 7.8%. Because some people attend the facility and they already are aware that they have hypertension or diabetes. So the number of newly diagnosed in that sort of effort is really quite critical in order to estimate cost effectiveness. And when we look at costs, so the median cost per person screened for NCDs was $1.7, so that is very low. But of course, many people will be not at risk of, they will be with good blood pressure and low glucose levels. So it is really important to know what is the cumulative cost per each new case found. So for each potentially new case found, it was for diabetes was just under $290 because of the slightly lower prevalence of 4.1%. And the cost for finding a potential new case of hypertension was $36 because the prevalence of hypertension was actually quite high. So this is really important to understand, then put it into context. How much does, say, a government or a provincial government need to invest in order to find someone who is not yet diagnosed, but at risk of potentially having hypertension or diabetes? So understanding the yield and cost of screening and case identification in unrelated health activities, so unrelated to NCDs, is an essential first step in understanding the feasibility and resource requirement for such initiatives. And with that, I want to take you to the next example. So the previous example was where people actually went to a healthcare facility because they had a health-related concern. In this case, they wanted to get a COVID vaccine. Now, of course, there are also community testing examples. Once more, COVID-19 gave us an opportunity to test integration of NCD screening into COVID-19 testing at taxi ranks in South Africa. So the taxi ranks, a little bit like illustrated in this picture here, are places where people go in the morning to catch one of those white minibuses to go to work. And during COVID-19, there was a service on offer to say, if you have any symptoms or you just want to double check, then you can get your COVID test here for free. So we said, okay, great. Anyone who would like to get that COVID test, we can also test them for hypertension and diabetes. And this was done in a population of just under 1,200 people at this public taxi rank. And what we found here was a diabetes prevalence of 7.1% and a hypertension prevalence of 27.9%, so slightly higher than what we saw in the vaccination study. And the potentially new diagnosed critically was 22%, which is an astonishing result to think that there were 20% of people who were found with elevated glucose levels, blood sugar levels, and elevated blood pressure, but they had no idea that they potentially have a non-communicable disease. However, then, of course, because it was a study context, we looked at linkage to care, and as you can see, linkage to care had massive gaps, right? So the diabetes rate of linkage to care was only at 16.3%. So out of all people who were tested with an elevated glucose level, only 16.3% managed to go to a follow-up in a healthcare facility, because of course that is what happens after the screening. And for hypertension, the linkage to care was around 30%. And you may remember from my first graph that there's 100% of the population, and the first step is the screening, and the second one was only the diagnosis. So here we look at the screening. Well, yes, people get screened and they get identified as being at risk, but because the linkage to care gap is quite big, the drop-off to receiving a confirmed diagnosis is quite high. So the screening approach demonstrates the value to integrated NCD testing opportunistically, because we identified many with a potential new diagnosis, 22%, in this NCD unrelated health activity. However, linkage to care must be strengthened for screening outside of health facilities to make the approach feasible. There's no costing component to this study, but I think this is something very important for follow-up activity after this. So really, if we think about what needs to change, I think in summary, it's really testing needs to move closer to the point of care to increase coverage and reduce the risk of loss to follow-up. Of course, today we know that point of care testing in public sector facilities is implemented in a fragmented manner. It's mostly at provincial level, and depending on the country, there are pilot projects of bringing, for example, HbA1c or glycated hemoglobin testing to the point of care under the national testing strategies. There's such demonstration example just happening in South Africa at the moment, where data are gathered, products are being procured nationally or subnationally, and then installed in facilities, and data are now being gathered about their uptake and the use of it. But it's often not done at a national level because there are many barriers to consider first for the governments to switch or improve testing, from the centralized laboratory to the point of care. We also really need to integrate testing into other health initiatives. And this is so important to me to demonstrate, because for sure, other health concerns will come along, right? I mean, of course, we have the epidemic health concerns like we see during COVID-19, and we may have other such respiratory condition outbreaks. But of course, we also have the regular testing facilities, for example, for tuberculosis or the HIV programs, where sometimes testing integration for NCDs is done, but it is not a routine activity to be included in all programs. And as such, we really need strong data to demonstrate that this is a feasible approach. Strengthening linkage to care is critical to make new testing approaches for early diagnosis feasible. There are initial examples to encourage linkage to care through mobile phone and digital encouragement of people to go to linkage to care, to have facility testing very close to primary healthcare facilities very close to other screening initiatives. But I think linkage to care requires a very tailored approach to really ensure that people are encouraged to go, particularly also with a link back to the community. We ran 2 or 3 years ago a very interesting project in India where we engaged with women's self-help groups who did a screening for NCDs in the community, also diabetes and hypertension. And those at risk were then referred to the facility, and then the community women groups were able to follow up with the community members. Did they actually go to the facility, and what happened at the facility? And then they were able to go through education with the people in the community to help them better understand why and how to take their medication, for example, and how to adjust their behavior that had been recommended by the doctor to not only link them to care, but also to maintain them in care and follow the advice that had been given. So I think there's a portfolio of approaches that are required, and from our side, we really think technologically there's a lot of room to move towards closing the diagnostic gap, as well as from an implementation operational approach. Yeah, and I think with this one, I would like to stop, and we'll hand over back to Guy, and we can engage in this. Thank you.
Very good. Thanks, Beatrice. Such an interesting discussion. We could discuss in the whole session. You started with it's really an ethical, moral dilemma where you started with that, of all those individuals living with hypertension or diabetes, only 50% of those are really diagnosed. And of those, you mentioned 1 in 4 only treated. Only 1 in 4 of all of those treated. This is really unacceptable. And I think it's really, this is using the example of a disease area that has very low cost diagnostics, treatments, and service delivery requirements. I wouldn't want to see the numbers on those which require more high cost support. But this is really unacceptable. I think this is one of the key areas of the pain points of our discussion going into the fourth item. Really, how can we really access? This is one a slightly underserved pillar of the NCD response, the access issue, affordability, availability, and quality of health medicines in the process. So it's such an interesting discussion, and I think you've landed on, and certainly the issue is not only, this is not the only bottleneck. Diagnostics is not the only bottleneck. There's a whole value chain of why the different elements of the health system that are not responding adequately. But I think you've highlighted one important area that could be unblocked, which is the diagnosis, the point of care, the integrated approaches that require the referral, the necessary referral systems in place. So I think that's a really interesting discussion. And we'll go to some questions, Beatrice, Kira, and my third panelist, my first panelist, sorry, Camila. We'll go back to some of the questions that have been forwarded into the chat, and thanks to Mark for forwarding those. There's some questions for all here. I think some of the questions have been answered that I've been picking up in the chat have been answered through the presentations, and then others have kindly offered answers in the chat. But we'll come back to some that have not been. I think the first question is Beatrice and Guy for us. What lessons learned during COVID pandemic could be applied to long-term management of NCDs? And I think you've touched on some of them, but it's really about that integrated approach, service delivery, integrated service delivery, and at primary healthcare. One of the main unacceptable lessons, also painful lessons learned in COVID, is that almost 80–90% of services to manage, control, prevent NCDs were interrupted during COVID situation because it was not necessarily the adequate integration required. The health system was strengthening. Do we understand NCD in primary healthcare? And really also insert attention to NCD management and control in emergency preparedness and response plans. So that was completely pivoted, obviously, towards communicable and COVID and pandemic responses, which did not at all include or have in the radar the attention to NCDs necessary attention. So that's part of the integrated approach, which Beatrice, you touched on, the need to, for the zooming in on the diagnostics element, lessons learned in COVID, the need to maybe ensure that we are integrating into powerfully and resourced and strong frameworks in other programmatic areas. Any comments on that?
Yeah, no, thank you. To me, I think what we really learned with testing in COVID is meet people where they are in daily life, right? I think this is sort of the taxi rank has shown that quite nicely, that this is their people's first priority, go about their daily life and earn their income, or do what they need to do every day. And that's where we need to meet them with those screening approaches. And it's not only through integration, but of course also there could be other activities that have nothing to do with health. Like, for example, we see often in the monthly cycles when people go and get their pension scheme payment, then they queue up somewhere. So that's an opportunity to come. But also importantly, what we learned in COVID, couple it with education, right? We saw so much education during COVID in terms of symptoms, washing your hands, wearing your mask. So it's that was critical and simple messages, right, to people to understand. And I think particularly for NCDs, it's important because there are so frequently no symptoms, and that's when we need to identify people, right? When they have the condition yet have not developed symptoms, which are often based on serious complications that are happening. So couple good education about why NCD is early NCD screening and testing important in management, and then meet people where they are, in terms of screening.
Absolutely, and that probably links to the participatory approaches. So how we are really engaging the communities, individuals in revisiting health responses and readapting as we move into emergency situations or otherwise. And I think you mentioned health literacy and communication, but there's this really also unfortunate understanding of misinformation during COVID and how that impacts the ability of individuals to access, understand, or request adequate attention and service delivery. So I think that's something we also have to address. That's a nice, important lesson in the research. I don't know if Kira or Camila, you want to add to that in that particular element? We have questions for you, so maybe you want to concentrate on the questions. There's one for Kira. What impact, in particular, the last one I think is interesting, was that will WHO Kira develop a new technical guide to implement the social participation handbook?
Yeah, thanks, Guy. And just maybe to echo, I very much agree on the point that you just mentioned on the misinformation, and I think that's key, and that's actually linking also to the participation. But to your question now, so the WHO Handbook on Social Participation is the normative guidance that stays there. What I was reflecting to is that we will develop some more operational tools. There will be also work that we have started in terms of developing a monitoring evaluation framework on social participation, understanding better how to measure social participation. So again, a lot which is drawing from the WHO handbook, but also from the other guidance and tools that have been developed by WHO. Guy, you very well have been involved with the WHO framework on people living with NCDs, etc. So we have been collaborating and drawing from the various guidelines and frameworks that they are available. But in this case, it is very much from the operational tool. We understand it's a 200-page document, a lot of rich information, but it's also in order to translate some of these a recommendation into operational tools, guidelines, and link to that actually also a note that we are in the process of developing an e-course as well in order to include and strengthen the capacities forward. So not a new normative guidance, but more fine-tuned opportunities and tools for different actors to use in their efforts and endeavors to strengthen social participation.
So additional support to countries. Nice, excellent to know. That just underscores again Rachel's commitment. We're sustaining our commitment to support countries in this point forward with additional support. There's a question on how we're supporting countries necessarily implement. I'll get to that, but I want to come to Camila. There's a question for you, Camila, which is if you can pinpoint to some of the recommendations in the Brazilian food guide, point to sort of, I think, food systems and how we're fighting obesity. We were talking about systems approach that has been supporting, that is the foundation of the Brazilian food guide. How is this addressing food systems in the realm of obesity? You're not able to unmute?
Yeah, I wasn't able to unmute. Thank you. Yeah, so I think that the main recommendation of the food guide in terms of changing food systems and food environment is to avoiding ultra-processed food. And this is a very innovative approach when it came out because it isolated a group of foods that it was driving the increase of obesity and non-communicable disease. And on the other side, it highlights that diverse diet which is already practiced in Brazil is a healthy diet. So by isolating this group of food that is driving this disease, it's a very innovative approach compared to nutrient, the previous food guide that was focused on nutrients, because we can then formulate policies to change food environment and food system.
Thanks, Camila. That's excellent. I think Mark also points to another publication study. I'm not sure if it's part of the guide. Mark, but thanks for that. There's a link in the chat for more information on that. I'm not seeing necessarily others. I will pick up another one there that says, how are we supporting countries in community engagement? I think that's extremely important because the social participation handbook and the framework are excellent frameworks for the situation and the principles, the actions, the enablers to move forward in meaningful engagement. But ultimately, what are the actions? What are the interventions required? There's sections in the framework that point to the actions, specific actions. There's just a menu of options. And ultimately, it is when we get to the ground, we get to the countries, we sit with countries, understand what is the prevalence, where are the gaps in interventions, which are, for example, some of the best buys that are not necessarily being completely contextualized and having the impact that we know they have, and having impact with some of the communities are not contextualizing and adapting to the needs of the communities. So really is when we get to the ground to understand how all this framework of actions, enablers, and interventions come together to support, for example, cancer agenda, cancer control. And we're doing exactly that in the EMRO region, Eastern Mediterranean region, where we're launching a project. We've launched a project to support 6 countries. Each country will have to define a particular area in cancer control, which would benefit from a co-creation, participatory, meaningful engagement of the experience. And we're putting together the whole multi-stakeholder environment to do so, dialogues, consultations, looking at the policy cycle. Where in the policy cycle we'll be doing certain meaningful engagement. And then certainly measure and assess how that has enhanced impact, scale, and certainly reach of some of these interventions. So I think we are moving to that. That's the first example of the pilot in one region. We're moving to other regions, but very important. All of this does not make any sense until we go to the ground, in a sense, and understand how we can implement and support countries contextualize these tools and these products. I'm seeing one more question here. I'm picking up. There's a question, Beatrice. There's two now, touching on the. I'll look at the first one first, but it was the trust or the reliability on point-of-care diagnostics.
Yeah, absolutely. And I've just put a reply in the chat with a link. So, I mean, there are many point-of-care devices, right? There's no lack of point-of-care devices being developed. Many good ones, but many also with questionable performance. So I think the key message is independent evaluation is critical. And I'm not saying everybody needs to do a big study, but certainly when you start using a point-of-care device, do a validation, right, within the facility, if possible, before making the commitment to a certain device. You will see in the podcast, my colleague, Dr. Priyanka Singh, is presenting at a diabetes conference, evaluation of 10 point-of-care HbA1c glycated hemoglobin devices. And there's particularly one image that is very striking where there's an international categorization of performance, gold, silver, bronze, standard, and the 10 devices have a very big spread. There are some in the good categories, but worryingly so, there are some in the very bad categories. So I think it's what we at FIND try to do is to analyze, generate data, because we appreciate that not everybody has the means and the ability to do it locally, so people can make informed choices. And even if the manufacturer has very good data to demonstrate, to show, validation is so critical, because otherwise trust is eroded. If a product is bought because it has a low cost, and then the clinicians realize actually the performance does not match with the clinical symptoms or with the history of the patient, then the trust is eroded, which makes adoption of point-of-care testing even harder, even for the good devices.
And then we invite participants to look at that link there with more information. I think we've sort of addressed the main questions here, and I think there's much more we can discuss. I suppose, Mark, that you don't mind that we make ourselves available for any follow-up questions or references needed or follow-up material that participants may need. We're available for that, and we will share the slides. I'm sure that the panelists have no problem in we sharing the slides, right? Excellent. We'll share the slides. We have more information and references. I think we'll be closing the panel. It's an excellent discussion, and I hope the purpose of the panel was clear. We want to spotlight some clear accelerators. We need to catalyze action quickly. We need to understand where the main pain points. These are 3 pain points that we are clearly identifying and already finding solutions, joint solutions, collaborative solutions with WHO partners and member states, Brazil itself. So I think we can much lessons learned here. All 3 of these particular areas are part of our reporting and our support to that 4th high-level meeting on NCDs. As WHO, as the leading technical agency, we are supporting the Secretary General in New York and the President of the General Assembly in that process to sort of scope, design, negotiate, and confirm a political declaration, which will happen next year. During next year, in April, let's say, to September, we'll be supporting member states in the General Assembly shape that political declaration. These 3 are certainly important priorities in that discussion, and we are providing this evidence, outcomes of this discussion, and some of the references and data that we've been hearing today. We'll be providing into that process in addition to other areas. But I hope this is useful to understand that we are all collaboratively working on some of these pain points. We are addressing the health inequity issues in the NCD agenda, which is extremely painful to see. We've seen 3 examples of where that is happening. And we are really identifying vulnerable populations. We are defining the NCD, those living with NCDs, as the vulnerable populations. That's the lesson learned from COVID. Really underserved, and they do present more vulnerabilities to infections like COVID. So NCDs is a vulnerable population. There's huge pockets of underserved NCD communities, which we need to address. So this is a small spotlight on what is possible, what is feasible. and hoping to provide you with more in future sessions. Thank you so much, Mark, for inviting us and myself in the panel, and looking forward for any follow-up.
Thank you.
Thank you very much.
Thank you.
You're muted, Mark. It's your turn.
Sorry. Thanks a lot, Guy, Beatrice, Kira, and Camilla. It was a very rich panel with some information that will for sure help the discussions here. So we'll provide so much for our participants, our members and network to to go ahead and reflect and plan their activities, their work here in Brazil. And I'm sure that since global audiences also watching us through YouTube, also they have a great time watching this panel. Thank you very much. Muito bem, agora voltando ao português, muito obrigado, agradecemos o nosso painel internacional, solicitei também que eles continuem, por gentileza, a responder perguntas e compartilhar recursos através do chat, então quem quiser fazer perguntas adicionais ou solicitar recursos, orientações através do chat, fique à vontade, né, usando o nosso